Um, we are closing our discussion now because our international speaker is already in show. That's okay. सबको enter करें. Yeah. Admit. Yeah. Can I talk now? Yeah. So, hello, Dr. Kapoor. Can you hear me? Hello. Did you put it on?
Can you hear me okay?
Yeah, I can hear you now. Can you hear me?
Yes, I can hear you as well.
Okay, great. So we had a little delay. So couple of minutes we got delayed starting here. So now our director ma'am, Dr. Taru Sharma is here, and we have auditorium filled with our PhD student, researchers, our other faculties, as well as our other employees to hear you. So you are hello.
Yes.
Yeah. So, please. So welcome you to today's talk, today's program on the World TB Day, and I'll briefly introduce Dr. because we are already kind of. Vivek Kapoor is professor of microbiology. Associated Director, Institute of Life Sciences at Penn State, professor of the Nelson Mandela African Institute of Science and Technology in Tanzania. Dr. Kapoor received his training in veterinary sciences in Bangalore, India, and PhD from Penn State and postdoctoral training from Baylor College of Medicine. He served as a faculty at the University of Minnesota College of Veterinary Medicine and Medical School till he moved to his current position. Dr. Kapoor's research interests are in global health and the mitigation of risk of major animal and zoonotic diseases. He currently leads multiple international projects on animal health and zoonotic diseases in Ethiopia, India, Rwanda, Tanzania, with support from Bill and Melinda Gates Foundation and the National Institute of Health and the Biological Threat Reduction Program. Today, he will share his recent finding on Mycobacterium tuberculosis complex infection in animals and discuss their implications for implementing and accelerating TB control program globally. Yes.
Great. Thank you so much for that, Papa.
I show you audience here. Director ma'am, But this we lost him.
Can you hear me okay?
Yes, we can.
Yeah.
Uh,
Apologies. I think something happened and we got bumped off. Thank you so much for the introduction. Apologies for the delay. A real pleasure to be sharing with you some of our work on bovine tuberculosis and zoonotic tuberculosis in India. Are you able to see the screen?
Yes.
Excellent. All right. So I'm going to be sharing with you a little bit of our experience on accelerating control of bovine TB. This is not just in India, but globally. We've been working for the past about a decade or so now to try and figure out what we might be able to do to accelerate this. And a key component of course, controlling tuberculosis is trying to understand what the zoonotic burden is. And so we've been trying to estimate as well what the risk of zoonotic TB might be. And we focused most of our efforts out there in India. So bovine TB, I think this is something you're all very familiar with, but I want to just make three major points out here that sometimes get lost in the discussions about bovine TB. First is that cows actually suffer terribly if they are not treated. It's a chronic disease and it can kill animals over months to years. And infected animals do spread the disease pretty widely before being diagnosed and otherwise dealt with in production systems. So it's a serious problem from an animal management standpoint if there are no control strategies. The second is that they are an estimated around 10% production losses, but these are really dodgy numbers. And the best estimates in production systems, for example, in the US and UK, is that there's actually no burden of disease associated on the productivity side with bovine tuberculosis test reactivity. And that's primarily because cows don't live that long. They have fewer lactation cycles within herd, and the disease doesn't really progress. But in context, when there is no control, this is an unknown number, but it's a really important number to know because that's what helps justify the economic aspects of why should a farmer or why should a country or why should a production system bother to control this disease. So what are the animal health costs, the real costs involved? And this is a big unknown. The third point I'd like to make out here is that TB is widely recognized as one of the world's most important zoonoses. In fact, earlier in the 20th century, it was pretty clear that TB accounted for a fairly large burden of disease, particularly amongst children. And approximately 10% of human TB infections resulted from M. bovis is what the thought was prior to the implementation of TB control programs. And I would add to this that milk pasteurization is perhaps the most important TB control program that was brought about. But again, this number is really not known. So what is that burden of zoonotic TB in human populations? These are at best guesstimates, approximations, and not really well known. So I'm going to share with you a little bit about what we've been doing to try and ascertain what this risk is, and then also to try and ask questions around what might we do about bovine TB, primarily because we know cows suffer terribly, and no matter what we do with intensification, the problem is going to grow. So we started off a while ago now, asking questions around what is the prevalence of bovine TB in India? And in a systematic review and meta-analysis that was performed by Srinidhi when she was in my lab, we estimated a pool prevalence of around 7% with reasonable confidence intervals between 6 and perhaps 10. But remember, this is based primarily on skin test reactivity. It just simply means that an animal is a reactor. Doesn't really mean that those animals have quote unquote bovine tuberculosis. And so given whatever we know about the disease and progression, the number is somewhere around this because the tests are not sensitive, and on the other hand, they're not specific. So we have to take these numbers with a big pinch of salt. However, if you take these numbers and then simply do some fairly straightforward, a little bit more than back of the envelope calculations, you end up with around 22 million infected cattle. Actually, these would be cattle and buffalo in India. That's a very large number. So that number is actually 3 times the milking dairy herd in the US. So just think about it. It's an incredibly large number. So how might one then start to deal with a disease like this? And then again, some very crude back of the envelope calculations based on productivity estimates that we extrapolated from studies done in Germany, of all places, in the 1950s. We ended up with around a 300 million USD, about 2,500 crore annual loss to production in India. But again, these are back of the envelope calculations, and there's a lot of uncertainty in these numbers. So what do we know for sure? So we know for sure that the disease is endemic in India. And why do we know this? Because animals not only test reactors, but frequently show up with lesions, either at slaughterhouses or animals that are incidentally necropsied for a variety of reasons within herds. The second, we also know that the disease does easily spread amongst cattle. This easy is a relative number. We know that the effective transmission number is well above 1. And depending on the context and depending with intensification, when you have a large number of animals that are co-housed, that number in R can be very, very high. In some of our studies in Ethiopia, for example, single super shedding animals can infect up to about 50 other animals in a relatively short period of time. So it's an incredibly contagious disease in context of intensification of dairy farming, which is something that we're pretty interested in doing for a variety of reasons. And then I just want to add on here, the human costs are huge and the animal costs are huge because the cows and humans end up suffering along with the economic hardships. So what do we know about bovine TB control programs? The disease was eliminated in places like the US and in Europe somewhere between the 1930s and the 1950s. 1960s. And this is with a very rigorous control program that involved testing of animals and then removing them from the production system, primarily by slaughter. Though early on in the 20th century, there was a very large movement, primarily around Denmark and other places, where initial control programs prior to test and slaughter were driven primarily by a test and segregate approach, but that largely lost flavor because nobody knew what to do with those animals that were reactors. So while this was eliminated in most high-income countries a while ago, national TB control strategy for both bovine and zoonotic disease in India is lacking. So what exactly is the benefit of control? My friend Alan Olmsted, working with Paul Rohde, has written extensively. Alan's an extremely well-respected economist. Has written extensively in this matter and basically said that in the US, when the program started between 1917 and then for the next decade and a half, about 4 million animals were committed to slaughter without compensation, or at least full compensation. but yet the program was a remarkable success. The reduction in human death and suffering benefited about 10 times the overall cost. This is both the private and the public costs of the program, resulting in approximately a saving of 30,000 deaths in the US. But remember, this is pre-antimicrobial antibiotic era, and at a time when milk pasteurization was just becoming a lot more common. So things were very different. Regardless, in the absence of a control program, and when you have low milk pasteurization and high burden of TB in human populations, the potential for benefit from TB control can be pretty substantial. So what are then the issues that made people like me really wake up to what might need to be done out here and how we might do this? I classify these, or our team classifies this, as being primarily 4 drivers of what we think is perhaps an emerging animal and public health crisis. So first, as we recognize, socioeconomic factors render test and cull approaches pretty much unfeasible. They're off the table. Not only in India, where it's primarily for social factors and cultural factors, but my friends in Tanzania, my Maasai colleagues out there, and they're my friends. They would rather, and I tell them that they have to kill one of their cows because it had a lump on a TB diagnostic test. They would not be my friends anymore, and they'd probably kill me before they want to kill their cow. So it's a serious problem in that this simply limits the ability for us to do anything with the only tool that we've known, right? Test and cull. The second part, which actually woke a lot of us up, was that we, and I'm speaking pretty broadly here, are very keen on intensifying dairy production. We're going from pastoralist systems to what are intensive dairy systems, production systems. And NIAB and others have been really helping drive that. How do we increase productivity? By getting in better genetics, by improving health, and that simply means intensification. The problem with intensification, though, is that intensification is the key recipe for disease transmission. When you put a whole bunch of susceptible animals together and you have one infected animal in that mix, you've now really got a problem. All of your animals are likely going to be exposed or will likely be exposed. And before you know it, most of them will be infected. So why is this a problem? So while the US started its control program sometime right after the First World War, for a variety of reasons, Europe didn't start it until after the Second World War, primarily economic, very distracted with a variety of things. And after the Second World War, most of Europe started this based on the US Marshall Plan and success of the program in the US. But between 1900 and 1950, when intensification was occurring in Europe and across much of the world, disease prevalence, TB prevalence went from the single digits, which is sort of what the situation right now is in India, to about 50-odd%. And it was only that intensification that drove that increase in prevalence. So when we sit back right now and say prevalence is low, with intensification, we know that it will become high. And this has been our observation as well in everywhere that we've tested this, Ethiopia, Tanzania, as well as in India. There are, of course, no current vaccination programs for bovine TB control, and certainly no approved therapeutics. And then, as we've already explored, that high both cattle and human densities, as well as consumption of raw milk, unpasteurized milk, would drive opportunities for zoonotic transmission. All right. So human TB, we already know, India has the largest burden of both TB patients and deaths in the world. In 2023, around 350 odd thousand deaths, which is predicted to be or suspected to be an underestimate. It amounts to just around one person dying a minute from TB in India. That's just staggering. It's just a completely staggering number. And of course, it has a large economic burden, especially amongst the poor. And then, as we're all aware, there's an increasing concern with drug-resistant tuberculosis. So we do have this national strategic plan for the NTEP for elimination of TB, which was between 2017 and 2025. The goal was to substantially reduce it. And this plan has had mixed success. So working with the Central TB Division in the Ministry of Health, we've been asking this question: what is the risk of zoonotic TB in India? And we call this the Erase TB project. And it's been supported by the Gates Foundation with support from other agencies. The premise for us was getting into this was that, in fact, you can't really eliminate human TB without controlling bovine TB. And so if there is this end game in sight that within India, we want to reduce or eliminate human TB, we simply have to address bovine tuberculosis, and we simply have to control bovine tuberculosis. So regardless of what we want, this is going to have to be a strategy that needs to be developed. When it's developed really depends on, and how much effort is put in there really depends on what the risk of transmission is right now. So we started working in sort of orthogonally, just looking again, scraping the data, asking things like, are there associations between bovine density and ownership and associated with, might be associated with human tuberculosis? And we get somewhat confusing results because buffalo density is significantly associated with risk of self-reported TB. But there are big differences between households that self-report versus the official reports. And there's also impressively a difference that cattle density and ownership, in fact, had a protective association. So you own cattle, you are likely to be protected. But you own buffaloes, you're likely to be at risk of self-reported TB. And those risks actually switch around if you're looking at official reports versus self-reports. But this basically drove us to this one point that in the absence of real data on TB prevalence and in both buffaloes and cattle, how we interpret this is going to be a real challenge. So we didn't really put much into this other than saying there's some interesting signals and we need to figure out what exactly might be going on here. So what then is the burden of zoonotic TB in India? When we started this off, the WHO had this definition, or actually all of the major organizations had this definition that M. bovis infection in human is defined as zoonotic tuberculosis. Of course, estimates were not available, and the most guesstimates, so whenever I spoke with people, they said, yeah, 5%, 10% when it's endemic in the country, but in India, that number must be closer to between 1% and 5%. Some people went up to 10%. Regardless, I think the point that we've already made out here is that as the burden of human tuberculosis will decrease, the relative burden in the absence of control of zoonotic transmission will overall increase. So we need to do something about zoonotic transmission as well. So we started working with some colleagues at this is before the pandemic. Started working with some colleagues at CMC Vellore, just asking a very simple question. If you took your first around 1,000 cases of TB that came into your clinic, how many of those would be animal lineage TB? And when we went into this, we asked this question of animal lineage TB, fully expecting that we would see M. bovis being the primary species that we recover, TB complex species that we recover. So after screening 940 of these sequentially collected isolates from patients, of course, CMC Vellore, which is located right there, gets patients a lot from the Northeast and a whole bunch from the South as well, but primarily from the Northeast. We ended up with 7 Mycobacterium aureus, 5 BCG, but 0 bovis, wild type bovis. This was absolutely stunning to us because we had totally not expected a result like this. And so in the Lancet Microbe, we had this paper sort of asking this question: should we reconsider bovis as a proxy for zoonotic TB? But this also starts to place a bound on what we might expect in this large referral hospital, and that is that we're looking at around 1% or so ballpark of animal TB lineages, so sort of at the lower end of when we started going thinking about what might be occurring out here. So just so for those of you not as familiar with, actually at NIAB, I think you are quite familiar with Mycobacterium aureus, thanks to the work that Dr. Day and colleagues are doing. Just sort of a big picture, the human and animal adapted members of the TB complex are pretty, it's a pretty genetically very similar group. For those of us who work on other pathogens, they're all pretty much the same, just different little lineages that have cropped up relatively recently. So they're genetically very similar. They're all immunologically cross-reactive. They all cause the same disease, tuberculosis. And what's important is that there are 4 main animal-adapted clades that really correspond to major host shifts. And I'll share with you what I think might be happening in terms of how exactly this happens. So we're looking at the bovis Capra clade, an aureus clade, and then we're looking at this additional clade around Pinnipedi, and then a variety of other relatively rarely recovered lineages from different wildlife species. So this particular group is suspected to really have occurred, the split has occurred and expansion occurred alongside human population expansion and migration, whereas this one's primarily thought to be within different host species evolved within Africa. So then we've been asking questions around if there's around 7% bovine TB in India, and there are these large number of infected animals, what are the lineages circulating in cattle? In humans, at least from that one survey, we saw that it's primarily aureus. And just to step back out here, because these are so genetically similar, all the previous studies performed in India that used a variety of different markers, UpB, a variety of different RDs, etc., couldn't really separate out aureus from bovis. So when people were saying this is bovis, well, we actually didn't know whether it was aureus or bovis, or in some cases even Capra. And so those studies that basically said we've got bovis, 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 because of the inability and the sensitivity of those assays, could well have been aureus or could have been one of these other animal adapted lineages. So we've started asking, well, what is going on with disease in India in terms of circulating lineages? And as you can see out here, we and others have increasingly shown that aureus is the primary is likely the primary lineage associated with cattle or buffalo or ruminant and livestock diseases, domesticated animal diseases in India, whereas you can get bovis in many other parts of the world that is spread. So why is there no bovis recovered from cattle in India? I wouldn't say no, but why have we not recovered, and why is this seems to be rare? I think this is really a story again of human migration. So this interesting story is that we have, of course, a large migration around 70 odd thousand years ago, and then around 50,000 years ago, a very large influx from Africa into India, which then formed the ancestral North Indian and ancestral South Indian trades, and then repeated around between 10 to 10 odd thousand years ago from Iran and the steppe region migration into India that effectively makes up what the genetic population in India. So we're talking around 50 odd thousand years ago, major founding events occurring with some modifications out there. And that's sort of what we know as well around the Indus Valley. So migration out of Africa, starting into the Fertile Crescent, and then from there around through the Indus Valley and then through into India. When you look at cattle domestication, as you know, cattle have been domesticated primarily from, there have been two independent domestication events, all from the Auric. One around the Fertile Crescent, which give us the flatback, the Bos Taurus cattle, and then second, the Indocene cattle, again, around the Indus Valley, which give us the Bos Indicus, the humped cattle. And when you look at the spread of these Bos Taurus, they went into Europe, went around into Africa as well. And the Indocene cattle, again, through trade routes, primarily into parts of Eastern Africa. And that's why you see a lot of these humped cattle here as well, but mostly concentrated around the Indian subcontinent. And then subsequently, there's been just a lot of trade. And when you follow cattle lineages across different parts, you see these same trade routes that have been occurring primarily. But a really critical component out here is that bovine genetics was starting to be imported into the New World, along with the colonial expansion. And so people brought in cows into many of these parts alongside the colonization of these areas. In India, when the British colonized India, when they brought their cows in, the taurine cows just didn't simply do as well as the Indocene cattle. And so until the White Revolution, so sometimes after the 60s, there was relatively few taurine cattle that were imported into India. But the really critical part is that in the 60s, TB was already eliminated in taurine cattle from the parts that were exporting to India. So the European areas, as well as the US, bovine TB had already been eliminated. So while the Europeans spread TB all over the world, they actually didn't spread it, and they spread it through infected cows. They never ever brought it into India. And so we have whatever it was ancestral in the Indocene cattle that are spreading in India. So that's why, at least our hypothesis is that you see Origus in India and not bovis. And that sort of makes sense. It's also consistent with many pilot surveys that we've been doing, and we're doing some much more rigorous surveys now. So you can find from a large fraction of animals that you screen in the hundreds at least, pretty much everything that you get is around Origus. So if you've screened around 500 odd animals, you get around 5% positivity. You then sort of necropsy some animals from some of these closed herds. All of them are Origus, so some are mixed with M. tuberculosis and sensu strictu. Our colleagues at NIRT have been running, as part of an ICMR project, a lymph node screen from cattle in Chennai. And again, they're getting that sort of 3 to 5% positivity rate of recovered culture positive animals, culture positive lymph nodes or tissue. Again, a vast majority of them are Origus and a few tuberculosis. And then we've been doing some abattoir studies, part of a DBT BMGF project as well. And we're also seeing similar sorts of numbers come out. But the bottom line is you either see Origus or you see TB. And Origus is likely spreading cattle to cattle, and TB is likely to be, as we and others have shown before, likely to be anthropozoonotic. So humans going to giving the disease to cattle. So Origus is in fact a pretty severe disease in humans. So it's not a trivial disease. Most of what we've shown, at least we found through our colleagues, Lydia, who's Dr. Jennifer, who's an assistant professor at Vellore, and Dr. Michael, who we've been working with for a while. In the study, we found that it's primarily extrapulmonary disease and with a significant burden of bone metastases or bone-related lesions, which are pretty concerning. So based on this, we and others have been pushing to update what we think should be the definition of zoonotic TB. We propose then zoonotic TB really should be nothing to do with bovis or not. It should be a form of human TB that's acquired from an animal source. Just go back to the pure definition. But we also said we need to use a pragmatic definition. And the pragmatic definition out here would be that ZTB is diagnosed really based on the epidemiologic evidence. So is there relevant exposure, as well as microbiological confirmation of a TB complex that is usually found locally in those animals. And so I think, and we published this earlier this year in Lancet ID, and the good news is that the WHO has now updated their zoonotic TB definition, and we're, thanks to Anna Dean and others at WHO, we are now working towards how we might update this. And the importance of this is that till we have a good definition, we can't actually get those burden of estimates. If people aren't looking for something, you're never going to find it. And till people started looking for Origus in India, nobody really found it. So then with our colleagues at the Central TB Division, as I mentioned, we've been looking at this project. What have we done? We've screened about right around 5,000 samples that we've collected, of which around 4,000 or so have been characterized from across the country. What we found is that you have a pretty high or relatively similar sort of burden of lineage 3 and lineage 1 across the country, with a smattering of lineage 2 and lineage 4. But effectively, you have some BCG bovis, as one would expect. This is the vaccine strain. And we've got 4 out of the 4,000 samples that we've processed across India. And again, these are contemporaneously collected, right? So not biased based on the relative number of reporting cases to primary to the TB centers and the primary healthcare centers are Origus, and of course 0 bovis thus far. Interestingly, we see quite a bit of dramatic differences in relative prevalence of lineages. So lineage 1 lives primarily in the south, lineage 3 lives primarily in the north. In the middle areas, you get an increased bubble of lineage 2, and this is a concern because lineage 2 is pretty aggressive lineage, tends to be more drug resistant as well. But very rare recovery of animal lineages such as Origus across the country. And this color, deep blue, you should be seeing there, but you can't because it's just not there. Right? I mean, there's hardly any of it there. Of course, we've been doing whole genome sequencing of these isolates, and there's some really interesting aspects that I can't go into because of time. I wish I had more time, but we have a paper that should be coming out explaining this. Bottom line, lineage 1 has been around a long time. It's the ancestral lineage in India. Lineage 2 seems to be relatively recent. Most of the SNP counts are well below 50. A vast majority of them are in the tens, suggesting very recent spread. Lineage 3 is younger than lineage 1 with a different distribution. Very relatively single peak. So it seems to be just a very large locally spreading lineage. Whereas lineage 1, you can see these 3 distinct sublineages in them. And then lineage 4 is the globally distributed, widely distributed, primarily European lineage that in India is relatively rare still. So the question then we're asking is, even though you get very small amounts of spread of apparently spillover of zoonotic TB based on our assessment of animal lineages circulating amongst contemporaneous human patients in India, what exactly are the risk factors? And so we have an NIH grant that we've just got started up, working with NIRT CMC in Tiruvallur. So these are all in Tamil Nadu, in Tiruvallur and Vellore districts, and a couple of different areas within them, where we're screening a fairly large number of animals and humans, and then looking in a nested case control study, what the risk is, as well as doing some very detailed workup of longitudinal workup of animal lineages that might be circulating out there. Our understanding is that it's only going to be these very detailed studies that are going to enable us to ask questions around risk and who exactly is at risk, what exactly is that risk, or is there protection? And if you're only going to do a cross-sectional survey, none of that's going to be revealed. So it's really important to do these longitudinal case control studies. So I'll just come back to this, these 4 drivers, as we mentioned. It seems to us, at least in the Indian context, even though there is a large risk of zoonotic transmission, at the present time, we see relatively small evidence of those animal lineages spilling over into human populations, which makes it really very interesting because that simply means that for the short period of time that we have before while our focus really should be on dealing with human TB as a human TB problem, human to human spread, and the animal component really ought to be driven by the fact that we're going to be intensifying production and cattle rearing, or buffalo rearing, and that our existing control measures are really unfeasible. So that drove us then to asking the question, what exactly does one do about this, and what alternate strategies might we put together? So the first thing we wanted to do was really accurately estimate the risk and the economic impact. So what is the burden of disease? The second is to establish what we would say are those technical tools and capabilities the diagnostics and vaccines, because primarily vaccines are going to be needed to deal with this. There might be a role for therapeutics, but that's a little bit less clear at the moment. And then together, with understanding this, doing this proper risk, understanding what the business case is, and having in hand these tools, it's only then we could start to think about what the sustainable market and policy drivers would be for implementing control programs. And before that, simply saying we need to do control, but without having really a good strategy for it, didn't make much sense to us. So this was really good and timely. This retreat that we had in, it's a while ago now, led then to a roadmap. Didn't really lead, they were doing this in parallel. A roadmap by the WHO, at that time it was still called the OIE, as well as FAO and the union, put together this roadmap for ZTB that effectively mirrors the same thing. I'll speak a little bit about in the last few minutes out here, and I apologize where we started late, so the time is a bit off. But what was the technical toolkit that we need to develop for TB control? It became abundantly clear that we needed vaccines to reduce transmission, and we needed improved antemortem diagnostics. Those with better specificity, particularly in regions with high environmental mycobacterial burdens. And then a critical part was to differentiate infected amongst vaccinated or animals in particular, because vaccines would be needed. So C.1 above. So a while ago, we came up with, working with our colleagues from the UK, a defined antigen skin test. And this defined antigen skin test enables us to relatively straightforward, based on a bunch of peptides, separate our BCG vaccinated from naturally infected animals that we've now validated in multiple different places, including in India at several different sites. So we're pretty confident that we have at least this part already done. Coming to vaccines, of course, you all are very familiar with BCG, the fact that it actually is a cattle origin vaccine. In fact, efficacy was shown in cattle in 1912, and then thanks to the First World War, when they had to stop their cattle trials, Calmette and Guerin actually only in 1921 showed its efficacy in humans. But by that time, the US had already started its test and cull program, which is showing to be great success. So because the vaccine interfered with PPD diagnostics, both the US and Europe decided not to use it for cattle treatment. It is, we know, pretty safe and inexpensive, and it has shown to have variable efficacy in humans, providing partial protection primarily to pediatric populations and severe diseases. So how might BCG work in cattle? Some animals are likely to be fully protected. Most animals will likely fall in one of these categories, that they're partially protected. They get in that if they get infected, they might recover faster. Or they might get infected and might not progress to infectiousness, or they might get infected and they might have reduced infectiousness. And all this partial protection part is one aspect of vaccination that's really important to consider. And then a fraction of animals will not be protected. Again, this is a partially protected. This is not a fully. It does not provide sterilizing immunity. So if you view this in a big picture standpoint, you look at a partially vaccinated herd, where you've got animals that have BCG vaccinated or those that are unvaccinated. You've got direct efficacy, just tells you the difference between the risk or conversion or infection between the vaccinated and the unvaccinated population. But indirect efficacy is really important as well, and that is that when you're reducing the burden within this particular herd, thanks to partially vaccinating some animals, so they're reduced risk, the difference between an unvaccinated group or a completely non-vaccinated herd or an unvaccinated animal in a partially infected herd gives you this estimate of indirect efficacy. And then totally the difference between vaccinated animals here and unvaccinated animals in this particular herd would give you the total efficacy. So we did a meta-analysis based on what exactly might be happening out here, and the results were really striking. It shows that the direct efficacy is very low, right? 20% ballpark. But when you look at that direct efficacy under natural transmission conditions, that's pretty high because all these studies were done with experimentally challenged animals. But when you look at this in natural settings, it's actually not bad. It's around 50 odd percent, but with an overall direct efficacy around 25%, biased heavily between the fact that many of these studies were done with direct experimental challenge. So we ask questions around what exactly happens if over time these disease is going to be spreading in the absence of any control. What would happen if you started an intervention like a vaccine? Does it go down like this? Does it go like this? Or where exactly what would happen? And so we started, those plots are not here, but basically when you do those plots, the data suggests that you can actually reduce burden pretty dramatically over time. To the point that you might even be able to approach elimination. So from our perspective, we thought that BCG vaccine for controlling TB appeared to be really promising. And so we have a paper that should be out next week that basically shows this. And so this is a 2-year trial. Actually, it's a much longer than 2-year to get here, but the actual experimental part is slightly around 3 years with 2 years observation periods in these animals. So this design is a really clever one. And my colleague, Andrew Conlon, and his colleagues came up with this one to try and dissect out what's the indirect efficacy of BCG. And just to be clear, this has not even been worked out for humans, right? So nobody knows what the indirect efficacy is of BCG in human populations or any other population that I'm aware of. So if you take 2 groups, so a control group, an unvaccinated group, and vaccinate some calves, and then you expose them to animals that are skin test reactors, so presumably infectious, some portion of them. And then you duplicate that group. So you've got 2 of those exact same groups out there. You then observe these for a period of a year or so. And then at the end of a year, you pool these animals from these 2 groups and you use those as the seeders for the next group. Again, unvaccinated and vaccinated with that group. And then you use these ones as seeders for the next group. And so this very quickly will tell you a couple of things. It will tell you what is the direct efficacy, so the ability of the vaccine to reduce susceptibility by simply observing these animals in blue out here. It will also tell us that what is the reduced infectiousness in this herd. And doing this study with about 300 odd animals, so it's a very large study done over a pretty long period of time. We find that reduction in susceptibility is around 58%. And this is, again, consistent with what the natural transmission meta-analysis had shown us. But importantly, the reduction in infectiousness. So the likelihood of an animal that is exposed to that is vaccinated to then become infectious is around 70 odd percent, which leads to a combined efficacy of close to 90%. And that is astounding in the case of something like BCG. And so when you look at animals that are vaccinated, exposed to those seeders that are also vaccinated, R0 is the confidence intervals well below 1. in this herd. So we then modeled this across in Ethiopia, where we actually knew a lot about disease transmission, cattle movements in different places. The study was done entirely in Ethiopia, where we can see that even in the absence of anything, you might be able to bring down within a period of 10 years to effectively, in some cases, effectively below the TB-free to below TB-free levels. So the target levels are what we want within as soon as 10 years. But in some places, you might not be able to bring them down, particularly if the prevalence in the herds is already very high. You may never bring it down. So if you're already at a 25% level, you're unlikely to be able to bring it down to the OTF levels. But you bring it down to levels where it then starts to become feasible to implement other control strategies. So regardless, this is a really exciting result, and we're keen to be moving this forward. So what are the findings then? TB is endemic in India. We know it results primarily from infections with oryges. We estimate currently a pool prevalence of 7%. That means about more than 20 million odd infected bovines. We also know that intensification in these herds drives that number up quite a bit more. And so this really calls for a need for active surveillance and control. We also have learned that BCG vaccine is a promising tool for intervention of TB control, and both the direct and indirect efforts that are measured from the first time in field trials suggest a high total efficacy, and this might then form an important component of a national control program or a strategy. We've also spoken about the zoonotic TB, and that ZTB case finding should really reflect locally prevalent lineages, and that intensive surveillance efforts are needed in order for us to assess both the risk groups and the risk categories of individuals who might be at highest risk of zoonotic TB. So we're sort of thinking about developing mission-based programs, accelerating around this. And I think if I were to move forward, I would really focus on the potential to develop these mission-based programs, initiating pilot trials with CARFOD vaccination, starting to the surveillance important out there, as well as building the diagnostic testing capacity, assessing new strategies for management, and then national bovine TB control policy. So a lot of people have contributed. A really privileged to be part of very exciting groups within India and across the world of teams that are thinking about how to accelerate bovine TB control in Ethiopia, in India, the UK, the US, and elsewhere. Our work is primarily funded by the Gates Foundation with help from the FCDO, as well as Penn State. And our work with the risk and the zoonotic part is an even wider consortium overlapping, at least in India, a lot of the same players, some of the same players, but a lot of our colleagues from the ministries, particularly the Central TB Division, as well as CMC Vellore. They've been really key partners for us, MGIMS as well. And then we're again funded by the Gates Foundation, NIH, and Penn State. I'm going to stop here and happy to take any questions. And apologies, it just took a bit longer than I'd hoped.
Yes, thanks, Dr. Kapoor. That was a really important discussion that your team and the global collaboration that you have built over several years, and so much of work has been done in the area of bovine TB as well as discovery of M. oryzae. epidemiology, how much infection is there in human, and that probably of disease vaccination of the cattle and what is the possibility or probability of protection. This thorough study are really novel. They will new policies for controlling livestock, the transmission that happens from animal to human, how affect or how it influence reduction. So, accelerating our mission for
Pardon me, ma'am. I can't hear you very well. The audio is not really clear.
Can you
Keeps
hear
breaking
me
up.
now?
Yes,
Can you
this
hear
is
me
much
now?
better. Thank you. Yeah,
Yeah.
thank you.
So thank you so much. Too early morning for you at the outset. I really thank you very much for being with us on this important day. The moment we were deciding about it, so the first thing and the first name clicked was Professor Vivek Kapoor. And my colleague back at IVRI, Danpat, used to not only used to publish, used to talk, and when we go, many people, and yeah, I mean, the literature. So everyone, and not only I thank, I also, it's very impressive and huge data, especially the 4 points which you just put. Very rightly, you just said it's a huge data, and you have good major counterparts, both in the side. I'd like to, just pin the same points, 4 points, as you correctly started. Is a socio-economic, or rather more of a social thing. Clearly, there needs, and you said it very boldly, which is true, we need to have a national strategic way, like how exactly we move. People are trying, but yes, I mean, it's not that we say we have to, but it has to be pinpointed. So when a lot of TB experts and one accomplished one like you, somewhere in the meeting, maybe the coming May, it could really be flagged in, would be a clear point. I mean, I would just like to say one thing. Second thing is that this institute, National Institute of Animal Biotechnology, you might be aware that we run One Health project. This One Health project which got started in 2021. And this is a true kind of One Health project, in a sense, houses 28 centers with the veterinary, medical, equal number of partners and wildlife. In fact, we have had our third meeting. It was a second annual review meeting. And what you said, our partners did not say any different. It was same. So one of the medical school, they shipped the samples, and 100 samples were shipped to one of your collaborating center and our friends and a collaborating partner to the One Health. So they have done the multiplexing, multiplex PCR, and the story was same. In the 100 samples, no mycobacterium bovis, and it's just 100. It's huge and conclusive. It's very important. And why am I talking this? I'm talking this because since you are moving in the Tamil Nadu belt, CMC Vellore and Tamil Nadu makes a huge data set. And what I was really impressed when you said that it's not only the sample from hospitals and human, it's also important the samples where these two are, twining together more closely. That makes more of a sense. So from Tamil Nadu, and when you move to Telangana, where the very important institute is housed, and it makes more of a sense at a global platform to to move along and handhold and kind of, as you rightly said, it's a huge teamwork and a lot of efforts. And we significantly, rather, with all humility, we acknowledge and salutes all the efforts through your data which you shared with us. The point I'm trying to make is it's also important to handhold these institutes like Biotechnology Institute, which have, you know, deep science built-in expertise, which will make the data more robust, more clear, and for surely it adds to the larger group. Uh, I heard a lot about you, and it's my first time hearing you. Uh, it's incredible. It's too good. Thank you so much. Look forward to interaction. Just, uh,
I'm sorry, ma'am, I can't hear you now.
could you not hear me when what I was supposed
Just the last
Yeah, I said
part. Yes,
you were
ma'am.
not late. You were precisely the 16 minutes because we started 5 minutes late. I'm sure you will be pleased to take
Sure.
colleague.
Thank you for the kind words, ma'am. And absolutely, I completely concur. And it would be a privilege to work with colleagues at NIAB and you. And my colleague Sindhura speaks really highly of you. And I'm looking forward to actually meeting with you in person as well.
Thank you. Good to hear that. Thank you very much.
Vivek, this is Nagendra from NIAB.
Sorry, you're just breaking up a bit. Oh, hey, hi, how are you?
How are you?
Oh, yeah, good to see you.
Hope to see you in person pretty soon. But my question is, skin test has been routinely used for screening. And I believe most of what we have been using is Bovis. So what is your comment on actually shifting to Origis PPD? I'm sure there will be cross-reactivity, but I do not know whether it will be the same numbers or same percentage as before where we were using Bovis. And in terms of field application, I think in India, the reach of the veterinarians and things like that, I think skin test is still feasible and probably easier to do. What would be your comment on doing that in India?
Yeah, great. Very good to see you again, Hector. Really good question, and the answer is going to be a bit different. I actually don't think there's any use at pursuing an Origis-based PPD, because I think the very conceptual framing of PPD is about 100 years old. It's very difficult to make. It's even more difficult to standardize. And if we go down that path, I think we're basically repeating the mistakes of 120 odd years. The best way forward is a molecularly defined tuberculin. And we've been working pretty closely with several colleagues. There's actually just 8 proteins. And if this was a talk on that, I would have spent an entire hour speaking to you how I think that entire path is going. There's just 8 proteins. We've reduced it now to less than about 10, 15 peptides that will give you effectively the same responsiveness as PPD does. And then, as you can understand, if you're just making synthetic peptides, easy to make, in bulk and standardize. So I think the sooner we move over to molecularly defined tuberculins, the better off we are. And India has this opportunity to leapfrog, right? So to go from landlines to way beyond smartphones in this particular space, and not bother with going down that rabbit hole of making an Origis PPD. So if I were spending any time and effort right now. I'd spend all my time and effort at trying to make that molecularly defined tuberculin. It would be something that would be fit for purpose, fit for India's purpose, and then ability to standardize and then replicate globally.
Personal question. This 8 to 10 peptides that you're talking about, is it conserved across the different species or?
Yeah. So just to be clear, there are 8 proteins that will give you the bulk of the, actually 4 proteins give you the bulk of the responsiveness. You have to add another 4 in order to capture the diversity of recognizing complexes because of the way the MHC alleles are distributed. These 8 proteins can be reduced to synthetic peptides between 8 or 20 of them, depending on whether you want to use a gamma or a skin test. Those are entirely conserved across all of the TB complex. There's like nothing. So whether it's TB sensu stricto, or it's Oragis, or it's bovis, or it's Capre, will all react to that. That doesn't mean that the disease is different in these animals. So TB might actually have a different set of responding antigens, but those antigens are all present out there. So the validation of this really needs to be pretty robust. And our experience has been, based on everything we've done thus far, that at least on a gamma response, so looking at a gamma, there's no difference between Oragis or bovis. We are doing these actual challenge studies right now. So we're challenging animals with bovis and with Oragis and with TB sensu stricto. We've been following the immune reactivation patterns. We've been surprised pleasantly at how quickly the antibody responses, trajectories in some of them actually rise. So there's an opportunity to actually get away from a cell-based or a skin-based assay to one that actually even might be an antibody-based assay. Yeah. So there's just a lot of very, very cool activity going on here, and I'm happy to share with you in a lot of depth. The trajectories of that response is really good, but to answer your question, yes, they are conserved. However, that does not mean that those are equally responsive depending on the kind of infection. And between Indicus and Taurus and crossbreds and different alleles that are present amongst these different breeds, there will be different responsiveness, particularly if you're looking at cell-mediated immune assays. And that's why I think pivoting to these mixtures of assays is probably the right strategy going forward.
Okay, thank you.
So,
Good to see you.
So I have a couple of questions. So the first I have a question. I'll take it later. We have another colleague.
Apologies, I'm going to have to leave in about 8 minutes or so to jump onto another call. Maybe you should use just the smaller mic, not the other one. Yeah.
Now you can hear me.
Now I can hear you. Thank you, sir.
So, you know, the issue of this multi-drug resistance, and this is coming in this with the phylogeny, we are seeing that these are so much related, you know, your bovis or I. So don't you think that we need to screen a new drug target? Because, you know, when I was getting presentation, only 5 drugs are available, 2,000 genes. So don't you think that we need to really screen the new drug target, which can really penetrate and explore a new area? What do you think? Avoid this multi-drug resistance.
Yeah, so I think, you know, it's a great question. Absolutely, there is a need to develop new drugs for TB complex, period. I think if I were allocating resources, I would focus my attention to developing those drugs primarily for human TB. That's where the greatest need is, and that's where the greatest risks are right now. On the animal TB standpoint, all of the orages that we've looked at thus far have been sensitive, and that's we're really grateful for that, lucky for that. We have not looked enough, widely enough for that, but we've really not seen susceptibility, particularly on the animal side. What we are starting to see, which is a real concern to me, is that we're seeing drug-resistant TB sensu strictus, so MTB, Mycobacterium tuberculosis, in cattle. And that is humans giving it to cattle and then cattle spreading it from cow to cow. That's a real problem. And if that starts to become widespread, then we're in real trouble. So I think if I were to allocate resources and spend my own time, I would absolutely pursue drug development. For TB, it's an area of great interest to a lot of people. On the livestock standpoint, I'm less keen on implementing drug-related therapies for cattle and for buffalo for two reasons. One, the economics just does not make sense, and it only makes sense if you're looking at the non-specific benefits that long-term drug regimes provide to cattle production, so sort of increased milk production, lowered risk to other diseases. And in India and other places, I'm aware that people actually use isoniazid at 10 milligram per kilogram body weight in cattle. And it's absolutely shocking to me that they get away with it, because if you are able to, our rules suggest that you need to withdraw, you need at least a 7-day withdrawal of the drug before you can sell the milk, but nobody does that. And so because of the drug residues that come into the milk supply with that, we have this underlying INH exposure to everything around. And that's a big risk from spreading drug resistance in our country. So that's something that I really worry about. But if I were to do this, I would look at alternate drugs. I would look at other drugs that are not used in humans to try and ask the question, what might be done there? So I'm not excluding drugs. I'm just saying that the kinds of drugs we want to develop for TB should be really, really very carefully thought about. Sorry, Bapa, I can't hear you very clearly.
Can you take one question now? Or...
Sure.
So, looking at your thousands of data, it's very low disease number, despite the number are very high in animals. So, what restricting origes to go to human? We still do not know. We didn't know for bogies also, and we still do not know.
Yeah, so I don't think there's anything restricting origes going to humans, other than there's just a lower risk of exposure. We know origes can cause some pretty severe disease in humans. I'll just give you an example. So our colleagues in Canada just published a paper in JID, and we've been working, exploring. They looked at immigrants, primarily South Asians, who end up with origes in India. So out of 600 odd individuals that had TB who came from India or the Indian subcontinent, around 20 of them had origes. So that's around 3%. And that's more than the 3% is more than what people coming from other parts had bovis in them. But again, it's 3%, right? But in India right now, you find it at 1% or lower. So what's the difference? The people who immigrated to Canada are getting this in the 50s, 60s, 70s. They're immunosuppressed now. So what it reflects is really a demographic of people, from mostly the Punjab, Haryana, that area that migrated. Secondly, they migrated at they're older people who likely drank milk directly when pasteurization was not really prevalent. So, clearly you can get it. Clearly it can go up to, at least in Canada, up to 3%. So there's no reason why it can't be a lot more in certain risk groups in India as well. Whether it's going to be aerosol transmitted, so air transmitted, person to person transmitted or not, is to me a less likely scenario because of the primary route of transmission. If it's primarily because of milk consumption or meat or exposure like that, you're less likely to get pulmonary lesions, even though pulmonary TB was pretty common in the Canadian population. That was mostly immunosuppressed elderly individuals. So, yeah.
Thank you so much. I will now program and thank you again for time for this talk. And I thank you, Dr. Ma'am, for really handholding and helping this program organization. And let's all of us clap for.
Yeah, thank you. Thank you again. A real pleasure and privilege. Looking forward to seeing you in person sometime soon. Okay, bye for now.
I'll catch up with you again. So much and attendees for being here for so long. Okay.